Froze there for a bit. Oh God, not my signal again.
Let me just see if the link is working as well.
It's not live on the Facebook. Have you got another link?
Oh yeah, watch live video. Okay, so actually, yeah, we're live now on Facebook. Have you got another link? Oh yeah, watch live video. Okay, so actually, yeah, we're live now on Facebook. Have you got another link? Oh yeah, watch live video. Okay, so actually, yeah, we're live now on Facebook. Have you got another link? Oh yeah, watch live video. Okay, so actually, yeah, we're live. Okay, so I can turn that off. So we're going to wait until 8 o'clock and then we'll start officially.
Yes.
If anyone has any kind of questions that they want to ask Sanj earlier, you can just pop that in the comments box. And we'll go over, once it comes to 8 o'clock, we'll go over the whole structure of the webinar and we'll discuss exactly what we're going to speak about.
Sure.
So you've been busy the last few weeks, Sanj?
Oh, it's been manic, absolutely manic. Run up to Christmas. I can't wait for Christmas. All the conferences have started again, and webinar and all the CPD courses.
Every few weeks you've been doing some webinars or some lectures or some presentations.
God, every other week in London, Manchester. We're due to go to Glasgow in December. I've cancelled that actually, thankfully.
Wow.
For a hands-on course, but no, it's
making up for lost time.
Well, yeah, I think people are excited to get back, really. But yeah, I need to pace myself next year. I think New Year. Quite a few courses booked, but to space them all out, really.
Yeah, exactly.
I don't know. It's just too much.
Okay, so 90 seconds, and then we'll be ready to start. Okay. I'm going to pour myself a little drink here so I can enjoy your webinar.
Actually, I've got to get a glass of water as well.
Mm-hmm. Got some nice French wine.
Teasing me.
Okay.
Turn that off.
Okay, so we've got a good few people logging on there now.
Yeah, I can't see them, but anyway.
Right, so I think Olivia's going to log on, just introduce the webinar, and then we'll be good to go.
Okay.
Okay, fine. So it's 8 o'clock officially. So this is our start time. So Sanj, many thanks for joining us tonight for the webinar.
Thank you very much, Anna.
Pleasure to host this. There's been so many webinars on for the last 2 years. I thought it'd just be nice to do a little chat rather than a formal webinar.
Yes.
And especially having someone who works in clinical practice all day, every day, it's really nice to have like a wet-fingered clinician to talk through kind of some of the challenges that we kind of all face in endodontics. So the
Yes.
title of the webinar is Endodontics, the Final Frontier, Challenging Cases. So, I mean, these are cases that everybody can face. You obviously get referred the more challenging ones. So this will be a really nice insight into see how you deal with them. So there's a broad outline of what we're going to talk about. We'll talk about challenges in diagnosis. We'll talk about in restorability challenges. So I'm sure everybody's the same. Everybody's been talking about how many cracked teeth that we're seeing in practice now after all the stress and anxiety that's been caused by the pandemic. And cracks have always been a really kind of challenge, even in the best of times, to figure out a kind of restorability prognosis, endodontic prognosis, and how we deal with kind of cracked teeth. And then finally, we'll get on to disinfection as well. So that's as a kind of broad outline of what we're going to do. As we've questions kind of come along, we can see, can we add them into the talk? But yeah, fantastic. If you want to start off then with diagnosis, that'd be great.
Thank you.
So
Thank you, Daniel.
Yeah.
Thank you, everyone. Thanks to those of you who've joined us on this cool winter, not quite autumn now, it's going into winter's evening here. Yeah, as Daniel's mentioned, I've got a kind of a broad structure of the topics we're going to speak about. So we'll kick off. It's going to be kind of clinical, really. I've thrown in a few cases, some of them quite recently, actually, that will hopefully illustrate the tricky cases that we often get and how I deal with them. We can have kind of a discussion. Feel free to pose any questions into the comments box, and Daniel will pick those up, and yeah, we can break the conversation up, as it were. So yeah, so diagnosis. We'll talk about diagnosis. This sounds pretty basic and fundamental. Those of you who are experienced in practice, endodontic practice, I don't mean to teach grandmother to suck eggs, but it's useful revision just to go through some of the things that are often missed, some of the classical features. Those of you who don't do endo day in, day out, it'll be very useful for you, because when we miss obvious diagnostic features or signs and symptoms out, we can often go down the wrong route, and that can lead us to problems. So, and we also need to know what's caused the original problem. So the cases that both Dan and I tend to get are retreatment cases. Someone's had a go at doing their endodontics, and for some reason it's not worked. So we need to be able to identify the issue that the previous dentist colleague encounters, because we've got to overcome that, and we've got to deal with that. So that's why diagnosis still is quite important. So let's kick off and talk about diagnosis. So it is kind of basic history and examination, the history of the patient's complaint, and not just the symptomology, the dental history, which is often quite important, because these teeth that come to us, they're either heavily restored or a combination of heavily restored and root filled teeth. So we need to kind of know the almost the timeline of what's been done, when it's been done, and when the symptoms started kicking in, and what was done to try and deal with the symptoms, if anything. In terms of longevity, if the problem's been there for a long time, and lesions, when we go on to our special test, we'll look at this, how the effect of infection above the tooth and the surrounding tissues, that can have an impact on the prognosis as well. So we do need to consider the timeline, as it were, of the symptoms, and essentially when we're doing a history and examination, we can't pinpoint a diagnosis just from this basic information. We're building up a picture from all the information, our conversation with the patient, what they've been experiencing, the treatment they've had. We're then going to throw in special tests, and then we're going to do our examination, and that all builds up a picture of what's going on. So it's not just what we find on a radiograph. It's not just what the patient reports back in terms of symptoms. They're just parts of the puzzle of what's going on. And as Daniel mentioned, we're going to talk about tooth fracture, which is, for me, I kind of call it the pandemic within the pandemic, because the number of, every day, at least one case has got a fracture. And the 3 cases I'm just going to show today, they're literally from the last 2 weeks. So and those of you who do referral, even in general practice, you must be getting teeth that are fracturing. And social history is important, because there are occupational reasons why patients may be under stress, and that causes parafunction. But obviously, because of the COVID situation, that's caused extra anxiety and mental health issues, and I'm sure that's had some effect or some influence on the number of cracked teeth that we're getting, and they're really difficult to deal with, and we'll speak about that later on. And then with the special tests, obviously, in terms of the symptoms, the classic symptoms of pulpal origin, just to remind you, the key questions that we need to ask the patient, the frequency, the duration, the type of pain, and irreversible pulpitis, I think, is sometimes very, very difficult because often the symptoms aren't localized. They're quite sporadic. They can be referred pain. The patient will say they've just got pain on one side of the face and they can't pinpoint a tooth, and it can be random. It could be triggered by the classic stimulus of heat or and it's really, really tricky to try and identify the cause because the patient wants to be out of pain and they come to see you hoping to get out of pain immediately, and sometimes it's not easy to pinpoint the source of the problem. So these are the kind of questions I ask, and my nurse is noting down in the background, and this just starts building up that picture, as I was talking about, of what's going on, the symptomology, and it will point us hopefully in the right direction before we do the clinical examination. And then on the clinical examination, we do the extraoral asymmetry and any signs of facial swelling. Patients will obviously usually come in and tell you that they feel swollen, but if there isn't anything obvious externally, intraorally, we're going to look at the soft tissues and classic signs of infection, inflammation, and also a lot of people forget about periodontal examination of a tooth, that once we've kind of honed into the area where the symptoms of dental origin are coming from, we need to then I do a 6 to 8 point pocket chart around the 3 teeth within the vicinity of where the symptoms are coming from, and in a patient that's otherwise periodontally sound, if you do see an isolated pocket, be suspicious. It could just be an endodontic lesion that happens to be draining through the PDL, but equally it could be a fracture, which we'll talk about later on. And this is easily missed. This was a post-crown tooth that came in a few weeks ago, and you can see there's a sinus on it anyway, so there's an endodontic lesion, but then there's an isolated pocket, and otherwise periodontally sound patient. So when you start seeing isolated pockets in a post-crown tooth, it's quite obvious what's happened. You can actually see on this magnified photo there's a fracture, root fracture. So the diagnosis is obvious. Treatment plan is pretty obvious without having to do anything too complex. But this can be easily missed if you don't do a PDL examination. Some of the other special tests, percussion is a special test. It's worth noting that, and it doesn't tell anything about whether the tooth is vital or non-vital. It obviously tells you the health of the periodontal structure, but there are many reasons why the PDL can be inflamed. It's not just endodontic. Obviously, it could be periodontal disease, but it could be things like occlusal trauma. It could be orthodontics. There's many causes of percussive tenderness, but it's useful to know that because that could be a sign of an apical periodontitis, for example, or if there is infective cause of endodontic origin, and also mobility. Let's go on to, in terms of radiography, and I still get cases referred to. This was a case that came a few weeks ago, and please retreat the 7 here, and this is the GDP's X-ray, but we do need to make sure we can see, before we start considering any treatment, the full root anatomy, just in case there are any complexities. We need to see the full apical tissues, or because 3-4 millimeters below the tooth or around the tooth, just in case. And this is the radiograph that I took, and you can see there's a fractured file that's been left through the apex. There also happens to be possible suspect perforation in the middle. I mean, that tooth, just from the radiograph, that there's also a buccal sinus, there's an isolated pocket, the furcation. There's a lot of negative factors on this, and you kind of get an idea that the prognosis for this tooth is a little bit dodgy, and is it worth investigating? In this case, the patient decided to have the tooth taken out rather than retreatment, which is probably a sensible idea in this particular case. And again, another X-ray that was sent. Please retreat the lower 6, but that's almost a bite ring rather than a periapical. In fact, this is interesting. This tooth was actually vital. There's a little bit of thermal sensitivity, hence the referral. There's a little bit of a periodontal problem at the back, but in fact, there was not an endodontic issue with this really. So just referred it back to have a classic restoration. Sinuses can be interesting. This was a case that came in last week actually, referred in for endo of the 5, but because there's a sinus above the 5. So what I did was I stuck a GP cone, and I tend to use a size 30. No local anesthetic, and usually you can penetrate into the sinus and track it back. And in fact, it came all the way back to the mesiobuccal root of the 6, which was interesting. So the 6 was the cause of the problem, but that can be easily missed without looking at the overall picture and doing vitality tests. 5 was vital, of course. 6 was non-vital. So this patient is scheduled for a standard primary root canal treatment of that. This is a case that was referred recently. Not a bad root filling. The root filling is a little bit gone through, but there's a chronic apical abscess, and there's some swelling below the tooth, crowned tooth. But we did a quick perio examination, and there's an isolated pocket of 9 millimeters. Otherwise, a bit of recession, but generally periodontically stable. But a 9 millimeter pocket, and you can actually see there's a crack on that mesiobuccal root. But on the radiograph, you can't actually see, apart from the lesion at the bottom, which is endodontic, there's no signs at all. The so-called classic J-shaped lesion that we see often on social media. It needs to be careful about judging a tooth just because they've got a vertical defect. They're not always vertical fractures. In this case, there is a fracture, but there's no signs radiographically, and this is something you can is picked up just from the examination. This was a case last week, I posted recently. This is a general dentist's radiograph and a non-vital, heavily restored tooth. There's a parafunction involved. You can see all the restorations are breaking up. But there was a distal periodontal pocket, and there's also a lesion. But you can see the bone loss. This is the GDP's X-ray. I took my own X-ray just for a bit of clarity, and you can see there's a vertical. In fact, there's a pocket of 8 millimeters distally. Now, most of you are probably thinking vertical fracture, but actually it wasn't. It was just simply non-vital. We picked up a lateral portal of exit. So essentially there was a lateral endodontic abscess on the tooth, but just a coincident distal periodontal pocket because of the loss of the contact point. So there's a lot of food getting stuffed between the teeth. So this is just a completely separate periodontal issue. Which is favourable, and there's no fracture. So once you sort the endodontics out, hopefully that will heal. But that looks like a classic J-shaped lesion, and you would say, it's
so that's a beautiful example of just a portal of an endodontic portal of exit going distally that's causing the bone loss. So other than an apical lesion, it's a lateral lesion.
Yeah.
So have you any advice then for general dentists in being able to distinguish between, let's say, the previous examples where the teeth were cracked and were found to be cracked, and a tooth like that where if you look at the X-ray alone, you would make an assumption that the tooth is cracked? So what's the kind of process that a general dentist should kind of think or go through in deciding which cases are worth investigating more and which cases you can decide, actually, this has got no hope? So should we be encouraging patients to dismantle and investigate, or should we be making decisions based on our exams, special tests, and radiography?
I think, well, as I said before, it's building up the picture. So you can't judge purely from the symptoms. You can't judge purely from a periodontal pocket. Equally, you can't judge from this so-called J-shaped lesion from an X-ray, special test X-ray. And I think in terms of fractures, you've got a physical visualization. We'll jump to that restorability of the tooth fractures. I think you've got to take the restoration out, and you've got to look under high power magnification and track that. First of all, see if there is a crack. And classically, it tends to be in the distal marginal ridge, doesn't it, or mesial? One of the marginal ridges on a posterior tooth that's heavily filled. And then you've got to trace it down. And some people suggest using dye stain. To be honest, when you've got a microscope or anything bigger than 7 to 10 loops, you will see a crack pretty easily. So I think it's a case of visualizing. You've got to visualize. For me, that's the main diagnostic tool. Basic visualization. Take the tooth apart and look for a crack, and then track it down. And then if it goes too deep, this is where it gets tricky. And should I carry on speaking about the fractures, actually, because it is pretty actually. So I mean, in terms of, I'll go through the basic classification. I use the American classification, the AE classification, which I think seems to me most logical. And you've got this craze line. The extent of the spectrum of cracks are simple craze lines, which essentially are just fractures within the enamel. This is wear and tear. These are occlusal forces over a period of time, and these are relatively innocuous. They don't cause any problems. They're just anesthetic, and you see this often in people who have got parafunction, but also older patients. But they're fine. The cracks are within the enamel. They don't breach the EDJ. They don't go into dentine. So they're not an issue. But I think it starts getting interesting when it gets a little bit deeper. So when the fracture does then penetrate into dentine, this is where it gets tricky, because on a tooth that's potentially vital, this is when bacteria start, over a period of time, not straight away. This is when they start percolating in through the cracks, and then they'll travel their way down the biofilm. The bacteria, it's not really biofilm, it's not really bacteria, it's when the biofilm start tracking down, and eventually you will get a pulpal reaction to it. And if it's left too long, eventually the pulp will die. So this is why teeth don't often die straight away. And when they're indenting, we've got to deal with them somehow, really, either seal them or not. In the vital teeth, you tend to get this classic crack tooth syndrome, and these are really difficult for our colleagues in general practice. I mean, what do you do with these things? Do you preemptively chase the crack into the tooth? I'm not a fan of that. I mean, I don't know. A lot of general restorative dentists would chase a crack. I don't know what your thoughts on that. I think you just end up destroying.
I don't think you can chase cracks, because I mean, the thing is, if you have elderly patients, I mean, virtually, especially people who have large amalgam restorations over a period of time, virtually every single one of their molar teeth and premolars can be cracked. So if you start chasing every single crack in every tooth, you can end up with like a huge treatment plan for every single patient that comes in the door. And I know that is an American philosophy of basically it's like almost full mouth reconstructions on nearly every patient. But it's like it's trying to get that balance right between what kind of can work and predictability. And it's really, really difficult decision making with cracks.
It's a trick. I mean, a lot of it's down to symptomatic treatment. If they're obviously feeling it, I have to say I've got my lowest 7. The end-mouth mesolingual cusp is, I can feel it twang every now and then, and I'm just thinking, what do I do with it? It's vital. It's not a problem. Check the vital, check every month, and there's nothing radiographically. I don't know. As you said, the approach in America would be to just do an onlay on it while it's alive to protect it. We'll just leave it. It's a tricky one, isn't it? When it's your tooth, it's a different situation to what.
No, absolutely. I mean, every intervention has consequences. So it's so if you start doing indirect or direct restorations on all these teeth, it's like it also has an effect on it as well. So it's trying to not cause problems by your intervention, but also not leaving things to just deteriorate over time as well.
I mean, what is the crossover? So from crazeline to fracture, obviously it's into denting. Now, again, visualization is quite important, and a really good tool is a basic tool is transillumination. If you shine through the back of the plate or lingual aspect, if a crazeline within enamel, the light will transmit completely through the tooth structure, so it's uniform. But when you start getting into denting, you'll start seeing, depending on the depth of the fracture, particularly if it's a cuspal fracture, you start seeing at the fracture line, you'll see diffraction of the light, and it won't go through. And this is kind of the classic sign that there is a deep fracture that's within the dentine. But then what you've got to do after that is then you've got to start accessing the cavity, particularly if it's symptomatic or non-vital. A friend of mine, I'm in a minute, he's a prosthodontist up in Manchester. So this is the way he approaches this. This was the upper 4 that had some symptoms. It was vital, but had classic symptoms of CTS. You can see there's fracture lines in the distal marginal ridge and an old amalgam in the tooth. So he took the amalgam out, the platal cusp pinged off, but still plenty of dentine. So we don't preemptively endo these. 10 years ago, we used to preemptively endo them, post-crown them, and do all sorts of things. We don't need to do that. We tend to do conservative onlays, biomimetic onlays, they call them now, don't they? Maximize bonding surface area and just cover them up. And if worst comes to worst, if they devitalize, you can do the endo through that. So we're quite conservative in that way. If the fracture is deep enough,
it's really useful to kind of take a step backwards as well. Just have a look at the overall occlusion. Check. So step back before you kind of come back in. Check all the occlusion. Check all the excursive movements. Try and get that, at least to build up a really good picture, and then try and build a plan over time on how you're going to treat the patient long term.
Yeah, absolutely. I mean, the parafunction is a big one at the moment. That's causing generalized tooth wear, but obviously tooth fracture, individual tooth fracture. There are a couple other causes, well, a few other causes. as well as the size of existing cavitation, and the masticating action. It still is obviously you could bite. Patients could bite on this hard object. This, the jaw, it overwhelms the jaw jerk reflex, and suddenly the tooth could crack. And thermocycling old amalgam restorations may have been the reason why that previous case fractured. There wasn't many signs of tooth wear, but it could have been the amalgam was expanding. Pins are kind of a no-no nowadays. And interestingly, tongue piercing and things like that, lower incisor, you may have noticed lower incisors have got multiple craze lines. The odd tooth may devitalize if there's no history of trauma or orthodontics. And these patients might have a tongue stub. So have a look at that. That's an interesting cause. And also this in Asian populations, chewing betel nut and things like that. This is quite a hard substance, and constant chewing, and it does put wear and tear and masticatory fatigue on the teeth. So it's something to look out for. And then eventually, sometimes the cusp will ping off. If you're lucky, it pings off within the tooth structure rather than subgingivally. And you can see in this case, there's just so much tooth wear generally, but the 6 is just given away on this particular case. The worst cases, I think, are the 7s. They're a bit of a nightmare because I've had so many of these teeth unrestored, and you get this classic distal crack, and they devitalize, and you think, oh my God, what do you do? What do you do with these?
Absolutely.
You've got to check. You just got to check.
It's a perfect tooth. It's got a pocket often associated with it as well. That's like 4 or 5 millimeters subgingival.
When you catch it, because even that's not always the case. If it's just cracked recently and it is a deep crack and it's devitalized quickly, it hasn't had time to develop that perio pocket. You think, what's going on? And it's kind of where on the timeline these cracks are picked up, whether you get a PDL defect or not.
So what's your approach then with a case like that on a young patient in their 30s?
Well, first of all, warning them that there's a crack in it. It may not be savable, and you access the tooth. You've got to access the tooth and then chase the crack down. This case came in a couple. No, this was a year ago actually. Lower 7, again, a classic. Lower 7s are the teeth that are most vulnerable because they're the closest to the TMJ, the nutcracker effect. This is the mesolingual cusp pinged off just subgingivally. Now, this tooth is non-vital, so there's plenty of other tooth structures. So I decided to just do a gingivectomy, get some hemostasis, build up a provisional core, just so I can get a rubber dam on and do the conventional access. And then the endo was relatively straightforward. I haven't got the x-rays for that, but essentially it's a straightforward endo on that particular case. In terms of strategy, I think if for coronal fractures, I think for we'll start at the bottom. If you've got a root fracture, if you've got a tooth fracture that goes straight through the roots and it's very deep, I think an extraction is all the teeth split. It's pretty much had it really. I think the current thinking is if you've got a crack within the tooth, but it's not symptomatic, the tooth is vital. Occlusal adjustment. You look at the general occlusion, a splint. If there's evidence of parafunction, I think we need to protect the rest of the teeth and be quite conservative. So I wouldn't personally go in and put an onlay on these teeth. I'll just monitor them and occlusal splint. I think be conservative and then review if symptoms do worsen. If they do worsen, but the pulp remains within normal limits of vitality, there's not this classic symptoms of irreversible pulpitis. There is a case for covering these teeth up with onlays, I think. Now, whether we do direct or indirect, that's a decision you've got to make. But about 20, these are the kind of studies that are quoted, about 20% of teeth that, if they're protected, 80%, say the other way, and 80% of teeth that are protected with some form of an onlay or crown will survive. The pulp will remain vital after 5 years. 1 in 5 of them will devitalize after that period. So there is a case for these teeth that start developing symptoms which suggest that the crack is getting deep and the pulp is becoming inflamed because there's possibly some biofilm there for covering these teeth up. So
it's a tricky one, because if a young patient or if a patient in their 30s is already developing a crack at kind of such a relatively young age, and you're hoping to retain these teeth for 60, 70 years into the future, it is a really tricky decision making, because it's like unless you actually identify the cause of what's caused the crack to progress to such a stage so quickly, the likelihood of being able to retain that tooth into that kind of long-term spell is going to be low.
This is our dilemma, because if we don't protect, I think nowadays we've got composites. We can be relatively non-invasive by using, rather than prepping the tooth and with a conventional onlay or crown, we can, in the short term at least, cover them up with composite and see what happens. But at some point, even composite's going to fail. So it's, the risk of not doing it is that the tooth will just split down the middle. So what do we, I have to say, if I started developing in my 7, if I start developing symptoms of reversible, I'm tempted just to put an onlay on it, because if that tooth goes, it's probably going to go completely. Then you kick yourself and think, I don't know. It's a tricky one. But nowadays with the onlay designs, they're so good. I mean, the digital stuff, they're literally so conservative, aren't they? You can be prepped with an enamel, and you're just covering over the without going to dentine at all. So I'm kind of more happy about having that done rather than a conventional gold crown, I think, like we used to do 10 or 15 years ago. Teeth that are non-vital, obviously you're going to have to endo them, but that's assuming the crack doesn't go too deep. I think that the difficult decision here is when the crack starts penetrating into an orifice, or not into the pulp floor. I think when it's in the pulp floor, the tooth's pretty much had it. It's almost not quite split, but the prognosis is pretty poor. But if it's just within a few millimeters of a canal orifice, and there's maybe no signs of periodontal, what do you do with those? Do you take a chance on them, or do you just say tooth's had it? I think that's the difficult one.
As you see, the upper 6s where it kind of comes down right to where the MB2 canal entrance is.
Yeah, so this is a case I had recently. Yeah, it's difficult. So you've got this classic one, haven't you? So you've got the crack under it's an MOD. It's heavily restored anyway, but it starts penetrating just into the MB1. We then take the amalgam part distally. There's a crack going distally, so effectively there's a mesial and a distal, but not quite in the middle of the pulp floor. The patient, she gave a consent to carry on. She knows that the prognosis is dodgy. There's no periodontal involvement. Do the endo. Endo's kind of routine. But what I do in these now is I use core buildup, flowable core buildup. I love SDR. It's one of the first products that came out. All the companies make their own version. But the thing about this, I like the tip of this because you can infiltrate in. You recess the GP right down, almost like doing a NIR core, and also apply the composite over the crack, so it infiltrates within the crack, which you may not get with conventional hybrid. And then you cover the whole tooth up. So you've got the flowable bulk fill. It seals off the fractures into the pulp chamber floor, and then you build up normal composite. You reduce all the cusps, and just take it completely flatten the tooth until the patient can go back and have the onlay done with a general dentist. So make sure it's out of excursive contacts completely. It's not about aesthetics at this stage. And I also tell the dentist, not when they make the new onlay, don't make it with fancy cuspal inclines, because you don't want to introduce any interferences in this fragile tooth. You can even see on the opposing tooth starting to develop fractures. So there's a bit of a parafunction thing going on here in this particular case. I think on another case, this was a dentist. She came in last week, referring dentist, pinged the buccal wall off the 7, completely sheared up, luckily just above the gingival margin. There's a crack mesially, extends just down. It stops just at where what looks like an MB2. Nothing in the pulp chamber floor. So she wanted to keep it because you're not going to replace that with an implant with a low sinus floor. The endo was a bit tricky. SDR again, just infiltrate all the fracture lines, and then rebuilt it and took it right out of the bite. And she's going to have she'll have a 3/4 onlay on that tooth now, just to hopefully protect it.
So in a case like that, how do you discuss prognosis then going forward with? So I mean, it's great to speak to a dentist because they're going to be able to understand it. But I mean, what do you tell, let's say, patients who are going to spend a lot of money doing a specialist root canal, a crown? So how do you kind of balance costs versus prognosis?
Well, it kind of comes down to, we haven't got that much evidence. We've got to look at these 3 classic papers that look at prognosis, and in fact, I'll talk about it now actually, because this is a situation where you've got a crack. I mean, this situation has had it. I mean, that tooth's knackered, isn't it, really? But there's this situation where it's just going into the orifice, and you think, oh, God, the rest of the tooth looks fine. I put it to the patient, I go, so you've got a really deep crack, so I've got to stop the treatment, take the rubber dam off, just temporize the tooth, because you can't obviously speak while they're lying back. That's not proper consent. They kind of feel a bit intimidated and they can't give it. So I sit the patient back up because you've got a crack, it's deep, it's not quite gone through the tooth, through the middle of the tooth. There are no signs of the crack extending outside the tooth, as in you haven't got a gum pocket, a perio pocket. We can try and save this, but there's maybe a 1 in 5 chance in 5 years you're going to lose a tooth anyway. What would you like us to do? I think most of my patients so far said, fine, 5 years. I get one, that's 80% is a pretty good odds, I think. And then they can have an implant. And most of them have taken it up. I don't know of any. I think it's the way you put it to them. If you're frank about the statistics, and I do use statistics. Some endodontists don't like using statistics in that way, but I don't know. I think it's useful. That's the way I think.
I think there's been a big swing though in the last 2 years between people really wanting to retain their teeth again. It's been I think there's been a huge swing.
There is. This is the kind of the papers that I found. The recent one, Davis and Sharp, is pretty well quoted now. But these are fracture lines just within the radicular dentine, but not without any periodontal involvement. And at 5 years, 80%, and Sharp's one is amazing. Sort of first 2 years, 100% survival, and then it drops down after 4 years to about 96 to 90%, and that's not bad odds. 4 years. That's pretty good. I'd have that if I had a deep crack in a tooth. It gets interesting when it starts getting those are cracks just into the pulp chamber, short of the pulp chamber floor. These are cracks going into the orifices. Now, only Sharif's paper was specific about how deep the crack went sub orifice, but that was 93% survival rate. 96%. Sorry. Yeah, 96% survival rate, 93% with signs of some periodontal pocketing, early periodontal pocketing in the first 4 years. That's still pretty high odds. All the others are about 82, 85%. Pulp floor, we know. I mean, there's 11 times risk of the tooth's going to be lost. So for me, if the fracture's in a pulp floor, I just say the tooth's had it really. It's not worth it. Personally, I think pretty much agreed on that. So it gets tricky when you start getting periodontal pocket, I think. So it is important to know what's going on outside the tooth before you start going into the tooth. You need to know just to make sure that there are no other signs. But based on those odds, 1 in 5 of the tooth dying or losing the tooth, that's not bad odds, I think. And most of my patients just they're up for it, really.
Yeah, I mean, it's also interesting as well. I've been doing a lot more of, so if the crack is going right down into the mesiobuccal root, we're trying to do is kind of plan for failure going forward. So try and get a restoration done in a way that it may be accessible again, where we can do a root resection of the mesiobuccal root, depending on where all the amount of dentine is present in the rest of the tooth. And we've done a lot of root resections of mesiobuccal roots where there's enough dentine palatally and distobuccally to kind of, it really comes down to the restorability of the remaining tooth minus that root. So kind of going forward, often if a tooth is lost in an upper 6 area, it's often not the easiest tooth to restore going forward if you want to do an implant, depending on the anatomy that's there. So it's really nice to have kind of a plan of action that if this fails in 5-6 years time, then this will be our next step as well.
I think it's important with this, if the patient is up for it, and you can't just go and do the endo and let the case go. You've got to communicate with the referring dentist, the general dentist. Well, in fact, so it starts off from the moment they leave the chair. So I've done my bit to mitigate the risk by flattening the tooth. It's out of all excessive contacts until they can go back to the dentist. I don't do any indirect work, so all the indirect work is done by the referring dentist. But I'll tell the patient, first of all, at the moment it's an issue because patients can't get back into the general dentist for sometimes 3 or 4 months because it's completely booked up. So you're thinking, oh, God. So I'll take the tooth completely out of the bite, cover the whole tooth. So I'll extend the composite core and I'll do an overlay over the tooth after reducing it completely. Like in those photos, a couple of those photos I showed that. This is the whole tooth I did. So where was it? Yes, I'm overlaying, but about 1.5 millimeters overlay of composite. I flatten the cusp completely on the assumption the patient can't get back in. And then I'll tell the dentist when they make the crown, just don't make it beautiful. because if you start getting nice cuspal inclines, there you're going to start into the risk of introducing interferences or lateral scarcer contact. So it's not. It's just about protecting the tooth, really, and just tell the
I
patient.
mean, it's all about communication. And if it's, I mean, the really nice thing about having the scope and being able to take photographs, that if there's problems later on, you can see exactly how much tooth structure is there to start off. You can see where the crack was previously. Then you'll be able to see where the pocket develops over time. And then it'll just help in the decision making going forward then, if there's still a kind of conservative option or whether the tooth needs to be lost.
One thing that's important also, I tell the dentist, just monitor the periodontal, just do a periodontal check every 6 months on that tooth, because as soon as a pocket develops on that side of the crack, then I think the tooth has to go quickly, or you reset the root, because you know the patient's aware of this as well. You know, as soon as the signs of gum breakdown, I use the term periodontal breakdown, the tooth's probably fractured. You need to get it out quickly and go down the implant route. Otherwise, if you lose a bone, then it gets tricky. So something else I tell the dentist is closely monitor the perio health over the next few years.
So what do we say then to our colleagues who place lots of implants and they're kind of screaming here now going, oh my God, it's like once the tooth's compromised, it needs to come out because we need to preserve the bone for our implant restoration that we want to do. So where's the balance in terms of trying to keep a natural tooth versus actually having a good side for an alternative restoration?
I think it is a tricky one, because you're assuming that the general dentist is going to monitor it. Because if tooth just gets lost and the tooth splits, I get that, I understand that they're going to lose a lot of bone. The other interesting thing, I've not had an implant. I've asked a couple of implant guys; they're not giving me a straight answer on this one. So if there's anyone listening, most of the fractures that come on these teeth, posterior heavily filled root filled teeth, they're mesiodistal in direction. Now, we know if you lose buccal platal bone, you need that for primary stability. I think the term still is. But what happens if you lose bone interproximally, mesial and distally? Does it matter when you've still got the buccal and lingual walls intact? If you get that vertical isolated, that vertical defect, does it affect the primary stability of the rest of the implant?
I think the key is if you've got teeth either side, that should heal favorably.
It should do,
I think,
shouldn't it? So I get the argument if it splits buccal or platally, because then you get that dehiscence, and that's not good. And soft tissue point of view, it's not good. But if you get a defect mesial or distally to the tooth, does it matter? No one's actually asked me that, so and answered that question. So does it matter? Okay, but even if you do get a vertical bone loss on the distal side of the lower 7 or 6, you still have an implant because the buccal lingual walls are intact.
Yeah, no, I mean, I think certainly for lower 7, I think a distal fracture isn't going to be catastrophic, because by the time you remove the tooth and let it heal, I mean, in the vast majority of cases, there should be enough bone there then to restore it.
Yeah. But I mean, that's the broader question of when to treat, not to treat. I mean, that's a huge topic. So the fractures is obviously the current thing at the moment, but I mean, there's all these other factors, isn't there? There's looking at the general condition of the tooth, whether there's enough tooth structure. You know, this is, you could make a decision by the time it's prepped, and designer preps are changing. We don't do full coverage anymore. So some of these teeth we can probably keep, when in the old days we probably wouldn't bother. But strategic importance, occlusion, and patient factors. Patients, you're right. Patients want to keep teeth now. The pendulum's swinging the other way from having the teeth out and implants. It's which is an interesting point, and even from our colleagues, that there's a lot of dentists I know and implant surgeons start referring again. And you place implants.
It's always a thing when their own tooth or their wife's tooth is affected. It's always very conservative treatment.
Yeah. But even with their own patients, I mean, there is a thing about implant survival, and I think that implants aren't the golden goose anymore, are they? They're things they're failing. Not catastrophically, but what the odds? What the statistics at the moment? 20 to 25% periimplantitis, mucositis rate. It's they're not. They need maintenance.
I think it's all in the treatment planning. I think it's just sensible treatment planning from all sides. So from an endo point of view as well, we need to be sensible in the cases we're taking on. I think it's just general restorative treatment planning is the key to all of these cases. Is identify the causes of disease, identify the causes of poor function, deal with those, and then make a plan within that fits into the patient factors as well.
Yes, exactly. And occlusion. Occlusion is a big one, isn't it? And designing the occlusion for the final restoration to try and preserve the tooth as long as possible. I think that's the thing. And in terms of the disinfection protocol, I mean, that's another topical area, isn't it? What are the ideal disinfection protocol? There's loads of new gadgets and devices around at the moment. I'm still old-fashioned, I have to say. Irrigation, hypochlorite, 5%. And it's just getting all this rubber dams obviously essential, but for me it's we used to be talking about bugs, didn't we? Bugs floating around, but it's not about the bugs, it's about biofilm nowadays. It's the stuff that sticks to the canal walls and it builds up over time. This is difficult. Hypochlorite doesn't get rid of this. You can't just wash this stuff out. You've got to cut it out with your files. And also then then you need something else to enhance the irrigation to disrupt this biofilm, which sometimes, as we saw in the fractured teeth, over a period of time, the biofilm penetrates into the tubules, and that's difficult, especially if it's been root filled before and it's been left festering for years. This is quite a difficult thing to deal with, isn't it? Then you've got anatomy, the isthmuses, and all this. This is stuff we're never going to get to. How do we get this stuff out? How do we seal it properly? This is the challenge, I think. This still is a challenge, to be honest. I think we can get around root canals and S-shaped curves and that relatively easily. It's all this stuff we've got to get out from the nooks and crannies. I think that's the stuff we haven't quite sussed yet.
Yeah, but I think getting to the end, though, was a huge kind of bonus, because at least if we can get to the end, you've got a chance to reduce the infection to...
Yeah.
It's like nobody knows what level we need to reduce the infection to, but at least if we can get to the end, we're giving it the best possible chance that we can do. And then it's just kind of what strategy do we implement to kind of optimize the disinfection protocols?
Yeah, that's it. One thing I like mentioning to general dentists, because everyone, I think everyone uses rotary or some sort of reciprocating device now, which has made our life easy for the last 15, 20 years now. We can open up these root canals and relatively predictably, relatively easily, now with less files, single files, maybe some systems. But it's the stuff that we leave behind. And I like showing this CT scan. I think this is from Ove Peters' thing. So this is the mesial root of a lower 6 or 7. You've got the MLMB, and we can prepare these beautiful looking root canals, and they look great on an X-ray. But it's all the stuff in between that we kind of can pack in.
Yeah. But see that's exactly why I really hate single file systems, because I think you're taking one big file and you're just trying to get to the apex with that file. It's like there's no room for irrigation in the whole. So there's literally, you're doing a dry file all the way right down to the apex, and all you're doing is packing all the infected debris laterally. And it's like, and especially when you get down apically, you never fill, it's very rare to fill lateral canals and stuff then, because you've just literally packed all the accessory anatomy full of stuff. So in a way, once I've started to do a lot more smaller tapers, I started seeing a lot more lateral anatomy being filled, because of that reason, is that you're not packing all the kind of infected dentine laterally. And it was counterintuitive at the start. I was trying to figure out, okay, why am I seeing so much more lateral anatomy, but I'm doing much smaller shapes, which is kind of counterintuitive what we're taught, that you needed to do bigger shapes to get better cleaning. But I found it was actually the opposite, that the smaller shapes, and then when I thought about it more, it's actually because probably I'm getting less of this dentine packed into the accessory anatomy, and that's why we've been able to actually clean it better, even though it's a smaller size.
Yeah. And then obviously enhancing, you're going to leave, it's impossible to get everything out. So this is where you do need to kind of enhance it. And ultrasonics is, for me, I mean, there's two technologies really. Well, there's more than that now, but there's a sonic and ultrasonic, and that ongoing debate, which is better. I'm a ultrasonic person, but there probably isn't much in between sonics, and using devices such as these just to activate passively, so these don't cut the dentine, as long as they don't touch the canal walls for too long. They'll just kind of enhance, and the acoustic stream will just cause the turbulence to get rid of all the rubbish that's left behind with this biofilm or debris. So this is the final kind of the final stage, the icing on the cake for preparation for me. This is something I'll do routinely with EDTA and with hypochlorite, actually, just to finish off the cleaning before we dry and fill.
What's your protocol in terms of timings on an infected case once you've kind of opened it up, all your preparations been completed? What's your timings in terms of time for sodium hypochlorite and EDTA?
So once I've done the canal's prepared, I will then do a minute EDTA with ultrasonics, 10 seconds. So the EDTA is in for a minute, but I'll do 3 10-second bursts per canal, then replenish it. My nurse is replenishing the EDTA solution because it does splatter everywhere. And then I'll go back to hypochlorite, and I'll do exactly the same, 3 10-second bursts in each canal. And then I leave it for about 10 minutes after that, just with the hypochlorite, but then change it every 3 minutes. So the tooth is left soaking in the hypochlorite with probably over 10 minutes, about 2 or 3 interchanges of hypochlorite just to replenish it. And that's my protocol. I mean, there's no evidence for it, but I just, the tooth's been in hypochlorite for the maximum time that the appointment allows me. So I think that works for me. What do you tend to do? What's your irrigation protocol?
So it depends. I mean, so if there's a vital case and the pulp has come out with whatever instrument I'm using straight away, then I mean the case is I don't need to wait for ages with hypochlorite soaking in the canal. If there's a really infected case, then it's I'll do all the irrigation, then I'll soak EDTA, as you say. Then I will heat the hypochlorite up. So I will heat the hypochlorite and I will
yeah, I'm going to try that. That's a tip that you mentioned. So using the F5P down pack, the 3504, that's a good idea, actually, to heat it in situ.
So again, it's just about increasing the efficiency of treatment. So I've spent a lot of time looking at each step of kind of the process, and it's like, so if I can increase the kind of reaction of the sodium hypochlorite reaction within the actual canals by heating it up and using the ultrasonics, and there's been some papers to show almost like 100% bacterial kill with heated hypochlorite and ultrasonic activation. So I mean, I think that really does help speed up. Now, you do need to be a little bit careful when you are using the heat in the hypochlorite that your preparation has been good, because you do see the hypochlorite really kind of moving through the canals. So there is likely to be a little bit of extrusion. So you can't have the heat tip wedged in the canal. You have to allow room for it to come up coronally as well. So it's just a little bit to be a little bit technique sensitive, but in terms of efficiency, I think it's a really nice tip to be able to get, efficient disinfection. And
what temperature do you tend to heat it up at? What do you set the unit at?
I set the unit at 180 degrees.
Okay,
Kind of activate it, just in and out, moving in and out of the canal over like 10 seconds. Then I will use the ultrasonic, then I'll replenish it, I'll heat it again, ultrasonic, heat it a third time, ultrasonic. And you can see how clean the canals are. The heat, I think, does make a difference in terms of efficiencies.
Yeah. As with any chemical agent.
And microsuctions, and it's like just to make sure that you're changing you're getting the whole hypochlorite out. When I think back to when I was in practice before I had a microscope, I think the needle just literally went into the access cavity. So it was never really getting any fluid exchange within the canals.
No, I think that's important. That's something I do, actually. So, I mean, you have these terms called passive ultrasonic, which you just literally fill up the pulp chamber and just activate it. But what I also do now is, well, I don't do it. My nurse is doing it while I'm using the ultrasonic unit. She's topping up the hypochlorite. So she's irrigating into the access cavity. So it's continuous. It's always replenishing. So it's not stop and start. And it's so I kind of do that continuous, and my nurse is involved. And they love it because they're kind of doing root canal inside the tooth.
I think it's so important to, as I said to you earlier on before we talked, it's like I've nearly centered all my practice around my nurse. So having all these wireless instruments makes such a difference. So it's like the more cords you have, the more difficult it is to do that. Whereas if you have a wireless heat unit, you have wireless endomotors, you have wireless everything, literally the nurse can put stuff into your hand without having to look up from the microscope. And in terms, again, of efficiencies, it makes such a big difference in being able to work faster and not dropping any of the standards of the things that you want to achieve in the treatment.
That's it. So another tip might be useful. I use a lot of hypochlorite. So I use 12 ml syringes. Big syringes, not the stuff I use in dental school, 3 mils. And so I use a lot of this. stuff and 5%. So there's a lot of stuff being used, and which is fine. In terms of new technologies, I suppose I mean, there's obviously the gentle wave, which is being pushed quite heavily in the States. Whether it comes over here, it'll be interesting. But there's laser. From what I understand of laser, it's kind of another way of activating the irrigant, isn't it? Using
it's energy been pushed. So it's basically it's just getting the irrigant around the canal system. So it's like you're using light energy to push the hypochlorite deep into the channels. So
Yeah.
I mean, I think the concept behind it is that you can do a minimal preparation and still get the fluid dynamics to move around the canal without structurally weakening the tooth.
I'm interested to see what gentle. I don't know too much about it because I think people also use it to deliver the sealer. I think, don't they? The bioceramic sealer somehow. I don't know how they do that, but you see some of the results. Very minimal preparations, and where the sealer's gone everywhere, and all the lateral canals. So, but whether it comes over to the UK, I'm not sure. Whether people are willing to spend the money, it's not cheap. So, but yeah, I mean overall, I mean endo is quite it's quite an exciting. It sounds a bit weird, but an exciting specialty to be in, and it's there's a lot of work. There's such a lot of work, and patients are willing to save their teeth a lot more. And with COVID, there's just I think all of us have just been inundated with the amount of work. I think the key thing is to optimize the way you work, make it as efficient as possible, as predictable as possible. You don't want patients coming back. You want them to for you to get good results and them to be out of pain. But not to forget, I think this is why I teach undergrad and postgrad students. Don't just get too closed shopped about the procedure, the endo procedure. Just remember you're the first stage of restoring the tooth, so you need to think about what's going to happen afterwards. Don't lose grip of reality and start doing things on teeth that are knackered, and it's so easy to do that. And even if looking canals, you can end up just drilling and drilling and drilling away. You need to step back sometimes and think, oh God, what am I doing here, and what direction am I going in? And so because the procedures, you can get sucked into the complex retreatment procedures sometimes without thinking about what's going on. So I think beginning with the end in mind, have an idea where you want to go, but then the pathway to get there. But every now and then, just stop, sit, sort of look back, and just think, are you doing the right thing, and readjust your path, or just change, be versatile. I think you have to do that.
No, Sanj, thank you very much. That was like an amazing webinar going through all the different options.
Yeah,
I know you've got a lot of surgical experience as well that we didn't even get a chance to kind of touch on.
Yes. Talk about CBCT, didn't we?
It's but I mean, I think that's one of the really amazing things about endo now. It's like we've got access to like so much technology between cone beam CTs for diagnosis. We have surgical endo, which is like massively changed prognosis from being a kind of 50-50 kind of gamble before to like really predictable success rates with it. And I think it's all about, I think for endodontists, is working with our colleagues to inform them of the kind of prognosis and success rates we can expect now.
Yeah.
But ultimately it comes down, as you say, to treatment planning and just sensible treatment planning, a global big picture first, and then focusing down on kind of the individual units too afterwards. But I think it's amazing how predictable most of the endodontic treatments is now, apart from cracks, which is kind of what we unfortunately focused on most of the time. Right, because in terms of decision making, that is kind of really, really difficult decision making. Whereas most of the normal kind of general cases we see, it's like we're not worried anymore about apical periodontitis. The success rates from conventional endos are so high. We've kind of ended up focusing on, okay, where is the borderline cases now? And often they are cracked teeth.
Yes. And until we find something that can weld cracks together, some sort of laser, that's not. We have to live with what we've got, really, technology and experience that we've got.
Fantastic. Okay. So what we'll do is, if there's any questions that come up, we can do them here. Otherwise, if they don't actually come up and we don't get them, we can liaise later and we can put them on our Facebook group, and we can try and answer any questions. But thank you very much for your time. I know how busy you've been for the last kind of
Thank you, Daniel.
months, and look forward to all your other contributions and stuff that we're going to have on Facebook as well.
Thank you very much. Thank you, everyone, for listening in. And thank you, Olivia Woodpecker, for hosting the event.
Amazing. Thank you. Bye, Sanj.
Take care. Cheers. Bye-bye.